Hello, I'm Dr. Fahim Khan, consultant rheumatologist at the Aut Even Hospital, Kilkenny, and I want to talk to you about the rheumatology talks about rheumatoid arthritis. I'm sure you guys would have heard about the name rheumatoid arthritis, which is quite a common disabling type of arthritis. This is quite common, more so in women than men, 3-to-1 ratio, and 1-to 2% of the population suffer from rheumatoid arthritis, which is an autoimmune disease, autoimmune arthritis. So let's talk about what do we know about rheumatoid arthritis. So as the name implies, it is a destructive arthritis affecting the joints. So let me show you first of all how rheumatoid behaves. So if I look at this mannequin there, the chart, and you see that with untreated rheumatoid arthritis, it progresses without treatment to severe destructive rheumatoid arthritis that's there. You can very, very clearly see it. And if I want to show it to you, the joints which are damaged, they are irreversibly damaged. That is without the treatment. So that's the problem with rheumatoid arthritis. So that's why early initiation, early treatment is very, very important. And there are special drugs used to treat rheumatoid arthritis. So we don't treat rheumatoid arthritis with simply painkillers or the counter medications. They can be used to treat the pain, but has no effect on the underlying root cause of the problem. So rheumatoid arthritis, just like I said, mostly it's common in women than men, 3-to-1 ratio. It can affect any age group, but we see more commonly in patients from 30 years of age up to 70, 80, 90, and increasingly with the elderly population, we see rheumatoid arthritis presenting as late onset rheumatoid arthritis. So rheumatoid is an autoimmune arthritis in which the immune system destroys the joints. So that we don't know the actual cause of rheumatoid arthritis, but there are certain environmental, genetic factor that predisposes a person to rheumatoid arthritis. So studies have shown that rheumatoid arthritis is more common in smokers than non-smokers. In some families, genetic association with rheumatoid as well. In certain population of groups, we see rheumatoid arthritis more common. So there is more than one cause for the rheumatoid arthritis. When the rheumatoid arthritis starts, it can start with pain, swelling, and stiffness, either in one joint or more than one joint. But normally we see the joints of the hands, the knuckles. These joints are normally affected in both hands. So we see these joints involvement, we see these joints. Rheumatoid tend not to affect the distal joint, which is near the nails. And rheumatoid tends to spare this joint. So it could affect the wrist, it can affect the knuckles, it can affect the small joints here. These are called the proximal interphalangeal joint. But these two distal joints here, they are spared in rheumatoid arthritis. It can affect your elbows, your shoulders, hip joints, knees, ankle, feet. But the lower back lumbar spine is spared. Rheumatoid can also affect the neck as well, cervical spine. So these are the joints which are normally affected. So the initial manifestation is pain, joint swelling. We see swelling of the joint associated with stiffness. And the stiffness in the hands would last for more than 1 hour. So up to 30 minutes, an hour of stiffness in the hands could be normal. But if it lasts over an hour or two, that's not normal. So patient presenting with joint swelling, even if it is one joint swelling, associated with pain and stiffness lasting for more than 1 hour, they should see their primary care physician or their general practitioners, so that they should be referred to a rheumatologist, or they should see a rheumatologist straight away to see whether they have rheumatoid or not, because the early diagnosis of rheumatoid arthritis is very, very important as regards their treatment. If patients are diagnosed much earlier, you're trying to prevent joint damage. Early start of these specific drugs are given to the patients, which are aiming to prevent joint damage, and the disease can be controlled in time. So We have discussed the type of joints involvement, but what would be the rheumatologist's role in diagnosing rheumatoid, or how do we diagnose rheumatoid? I think it's very important not to ignore if you have one joint swelling persistently, or let's say a few weeks to a month. That's not normal. If you don't have any history of injury or fall or something that would have caused this problem, somebody presenting with one to three or more joint swellings, it should be taken more seriously. And a rheumatologist should see a patient regarding further tests that should be done. So when I see the patient, we would take a history, examination. We use this ultrasound as well, musculoskeletal ultrasound. If you look at in my examination room, we have the ultrasound machine somewhere lying down there in the bag. So it's a bedside ultrasound, and we can see the joints very, very clearly, whether it is swelling or not. So we can see very clearly this is the so-called synovial swelling, the swelling here. This is what we see on the ultrasound very, very earlier than they are manifested on the x-rays. So once after the examination, the rheumatologist would confirm this patient has rheumatoid arthritis. We want to make sure that the patient is started on the treatment ASAP, as soon as possible. So first blood tests are done. There's special blood tests that we check them. We look at their baseline liver functions, their routine blood tests, their inflammatory markers, SED rate, ESR, C-reactive protein, CRP. They are normally elevated in patients with rheumatoid arthritis. And we also look at what kind of medication patient is going to benefit from starting them. So x-rays can be done as well to look for joint damage, but since we have a bedside ultrasound, we will have a very good idea. We can also document, apart from joint damage, apart from swelling of the joints, whether the patient have suffered joint damage or not. So these can all be documented in first visit to a consultation to see a rheumatologist. And since we have the ultrasound here in my clinic in Aut Even Hospital, Kilkenny, and which is a bedside ultrasound, normally the ultrasound could be taken to different remote clinics during consultations for patients to look at the joints and to confirm the diagnosis. And at the same time, once the patient on treatment, we also look at using ultrasound to see how much improvement there is, to look at resolution of the swelling. So ultrasound does help. It has many, many uses apart from, which I'll talk to you later on next videos about what sort of benefit we get from using ultrasound for even injections, things like that. So there are some blood tests that we order them for patients. One is a rheumatoid factor. So rheumatoid factor is an antibody that is positive in up to 60 to 70% of patients with rheumatoid arthritis. It could be negative in 30% of patients. So we do rheumatoid factor, another test called the anti-CCP antibody test, cyclic citrullinated peptide antibody, which is positive in up to 90% plus patients, so 92, 97%. So very specific towards the diagnosis of rheumatoid arthritis. And the anti-CCP antibody also carries a prognosis, or it's like a prognostic marker. So it is a bad prognostic marker for rheumatoid arthritis. If the test is positive, if the count is high, it's associated with destructive joint disease. In other words, leads to joint damage. Similarly, if the count of rheumatoid factor is very high, that means that it's going to be aggressive rheumatoid arthritis. So rheumatoid arthritis, after we do the blood test, if required, we do further connective tissue test, particularly in women they're presenting. We want to make sure there's no coexisting autoimmune disease like lupus going on. So we also check their anti-nuclear antibodies, and there are a few other blood tests, then we will do them. But right now, straight away, once the patient presents, we would put the patient initially on medication. They're fast-acting. So mostly steroid or cortisone are used. The benefit of using steroid, it works rapidly straight away. It prevents joint damage. So patients who have no contraindication for the use of steroids, like diabetics, we would put them on steroids initially. And at the same time, if we know their liver function tests are fine, we'll put them on the first line drug, which is a drug called Methotrexate. let's talk about methotrexate. Methotrexate is a disease-modifying anti-rheumatic drug. This medication is also used to treat many different types of arthritis. So it was initially called or used or is used as a cancer drug, but we use it for rheumatoid arthritis. So before it was used for rheumatoid arthritis, methotrexate was used in cancer medicine, but we use it in a very low dose, and it has great results. It has we have over more than 40-50 years of experience using this drug, and it is well tolerable. But most importantly, methotrexate is a medication that we have to use it cautiously in patients. So we want to make sure that the liver is fine. There's no increased risk for methotrexate toxicity. We would advise the patient, if they drink alcohol, they should be very, very careful not to drink too much of alcohol, because you need a healthy liver to detoxify methotrexate. So it's best that the alcohol consumption should be very much minimized. There's no hard and fast rule. I always tell my patients, just be careful with alcohol. I mean, maybe no harm not to drink any alcohol until your first set of blood tests are ready, but you've got to be careful from alcohol intake. And if you look at the guidelines, patients shouldn't be drinking more than 1 or 2 drinks of alcohol in a week, and that varies from patient to patient. There are some medications that can also affect the liver. For example, even simple painkillers, anti-inflammatory medication, over-the-counter, Tylenol, Tylex, Advil, paracetamol, ibuprofen, Nurofen, all those type of medications are available over the counter, and they can cause liver strain, liver damage. So we advise the patient not to take all those medications, should minimize them while they're taking methotrexate. So once they are put on dose of steroids, patients are also put on methotrexate. We normally start a low starting dose of methotrexate, which is 10 milligrams as once a week, and we advise the patient to take the methotrexate in the morning after breakfast, once a week only. And also patients are started on folic acid, which is taken the following day. So normally patient would need up to 1 milligram per day, or maximum 7 to 10 milligrams in a week. And that folic acid ideally should be taken the next day. But methotrexate in the beginning would take a week or 10 days for the methotrexate to start working. So it doesn't work on day one. It could take a week, couple of weeks. That's why the steroids would kick in first before methotrexate would start working. It could kick in after 2 to 3 weeks. And we see the patient after a minimum of at least a month to 6 weeks. And the steroid initially are given for 2 weeks, and then the patient are taken off the steroids. And the steroid dose we use is a low dose, like 20 milligrams on day one, tapering it down, slowly reducing it down to 0 milligram in 2 weeks' time. So that dose should not cause any side effects as such. And then we call the patient, see them in 2 weeks' time, in a month's time, and roughly we check their blood test, mostly make sure the liver is okay. So patient gets their blood test done. There's a protocol to get the blood test done while they're on methotrexate. So most importantly, the first thing we look at is liver, and they are checked normally 2 to 3 weeks later after starting methotrexate. And then we see them with their blood test, and most importantly, inflammatory markers, because we target that level of inflammatory markers with the dose of methotrexate. When we examine them after a month or 6 weeks' time, we do their history examination, ultrasound examination on the joints, look for the swelling, that is the synovial swelling, whether it is settling or not. And if there is still ongoing disease activity of rheumatoid, we adjust the dose of methotrexate, slowly increasing it up from 10 to 15 to 20, and slowly we go up on the medications there. So patients are normally in the beginning followed up by, let's say, monthly or 6 weekly to, once their disease is well controlled, then we see them 3 to 4 times in a year, or perhaps 3 times in a year to twice in a year. And so patient also given instructions as regard to their blood test monitoring, to make sure they do hand muscle strengthening exercises and so on. Now there are some patients who may need more than methotrexate, and these are injection called Biologic Therapy. Biologics is a name for antibodies. So if we see that there is a guidelines for the use of biologics, we'll put the patients either straight away on day one or if methotrexate, if that full dose of methotrexate is used, which is around 25 milligram once a week, and despite that the patient is showing increased disease activity and have been on methotrexate for 3 to 6 months, then there are indication to be started on injection treatment, which is biologic therapy. And there are different types of biologic therapy. For example, we start with the anti-TNF alpha biologic therapy inhibitor, and the example would be, this is just to show an example, there are these type of pen devices, and this one is the example for a biologic therapy called Humira injection, Humira. There are so many of them. We can have another one which is called Enbrel injection. This is Enbrel, and this one is the Humira, the red one. And they look quite similar. If you look at them, and their technique is very, very easy to administer. Click, and just it's a click device, and they are injected mostly on the patient thighs or the lower part of the abdomen. So this one is called Enbrel injection, which is anti-TNF. It's used once a week, and there are of course benefits of all this biologic therapy. This one is another anti-TNF, the Humira injection. Difference is this is given every 2 weeks, but there are so many of them. There are some injections given once a month, and there are different ladders of these injections which we use them accordingly. We always start with the first anti-TNF therapy, TNF alpha inhibitors, which are the examples I gave it to you. Before patients are put on the biologic therapy, we want to make sure they are screened for TB, which is a latent tuberculosis. So it's a protocol, everyone should be screened if they go on the biologic therapy. So we do a TB test, which is called a quantiferon TB test, which is quite sensitive and specific as to outrule TB in the system. And sometimes chest X-ray is also used to look for scarring in the lungs. So once the pre-biologic screening is done, then patients are commenced on the biologic therapy. Of course, we recommend to the patient that they should have a proper vaccination for flu vaccine, pneumococcal vaccine in Europe. In US, there are different protocols. They would get hepatitis vaccination as well, and so on. So these vaccinations are done before they are started on the biologic therapy. And with biologic therapy, the blood test monitoring is important. However, with biologic therapy, just like methotrexate can affect the liver, biologic therapy can affect your immune system, and some patient could have perhaps more frequent chest infections. So once they are on pneumococcal vaccination and they have had their pneumococcal and flu vaccination, very unlikely they would have recurrent chest infection. But we will still advise the patient that if they develop very bad chest infection, it's best that they should see their GP first, start the antibiotics as soon as possible, and in some of the patient the biologic therapy is temporarily stopped, so to give time for the lungs to recover, the chest infection to clear up before they'll go back on the biologic therapy. So these are the protocols as well. There was previously a misconception about the biologics causing cancer. Studies have shown that apart from there's a particular type of skin cancer associated with biologic therapy, which is more to do with exposure to the sunlight, and the rest it is pretty safe, and there is almost no link as towards the increased risk of cancer with the biologic therapy. So it is better that if you guys are going on sun holidays, better to protect your skin, with the sun protection cream, things like that, if you're on biologic therapy. Rest, unfortunately, rheumatoid arthritis itself, there's in patient with rheumatoid, there is a slightly increased risk of cancer, lymphomas, things like that. So we all know about this, and this has nothing to do with the biologic therapy. In fact, biologic therapy keeps your arthritis very well in control. So apart from this, these medications, physiotherapy and exercise program remains to be a part of treatment for rheumatoid arthritis, and we always advise the patient that they should do the hand muscle strengthening exercises with a tennis ball, squeezing the tennis ball 10 times twice a day, low impact aerobic exercises like stationary bike, walking, things like that, that increase the strength of the muscles. and helps you as regards to joint stability point of view. So exercise is very, very important as part of the treatment of rheumatoid arthritis and understanding this condition, because now with the rheumatoid arthritis, if the patient started on the treatment, the disease is halted and further joint destruction is totally minimized. And we have wonderful medications available to treat rheumatoid arthritis with all these new biologics. A lot of research is also being done, so patient can live a normal life and they can do whatever they want to, whichever job they want to take. So their disease is halted, stopped with the new medications available. So the outlook has tremendously improved as regards to the treatment available we have for patients with rheumatoid arthritis. I have a lot of information on my website, www.arthritisandpainclinic.com, if you guys want to have a look at it. Rheumatoid arthritis, excuse me, any information that you guys want to look at, it is readily available. If you have any questions, concerns, please do not hesitate to excuse me, contact me on my email contact details, rheumatologyclinics@gmail.com. So rheumatologiclinics@gmail.com, and the website details are www.arthritisandpainclinic.com. So I could show you guys the information there as regards to contact details. So I'm Dr. Fahim Khan, consultant rheumatologist in Aut Even Hospital, Kilkenny. Thank you very much, guys.